Sir, we are live now. Shall we start?
Yes, we can start.
So, good evening, doctors and all the participants. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's session on GDM Updated. It's a very interesting topic, as we all know, and our guest speaker is Dr. Panchanan, sir. Before moving into the session, let's have a look on our Shield Connect page, our knowledge sharing platform of Shield Healthcare. This is the Shield Connect page. Here you can find different blogs, different recent blogs in many topics across India, written by many eminent doctors. And these are the first webinars already we have conducted in our platform, that is Shield Connect platform. And we have many awareness program as well. As you can see, that PCOS awareness, menopause awareness, GDM awareness, immune booster, COVID-19 updates, and thyroid awareness. In each and every tab, you can find all the related information of all the respective diseases. And not this is the most important thing is of our key opinion leaders. Currently, more than 500 doctors are currently supporting us, this knowledge sharing platform of Shield Healthcare. And so I request all the participants, please have a look on this website. It's very important in terms of our subject area. So now it's time to start the session with sir, and it's my honor to introduce sir. Sir is the professor and head of the Department of Obstetrics and Gynecology, Guwahati Medical College and Hospital, Assam. So with the short introduction, I request sir to take over the session. And meanwhile, I request all the participants for your active participation, and please post your queries on the Shield Connect dashboard, so that once the talk will be over, we shall have a short discussion on this topic with sir. So thank you, sir, and over to you, sir.
Now, good evening, everybody.
I guess there is a problem in the sir's end in terms of network issue.
Participants, please wait. Sir will join in a while. So kindly wait for sir.
Dr. Suman, the network issue, he will join.
Yes. Can you please contact sir?
Sumit.
Yes, sir.
Sumit.
Yes, sir. হ্যাঁ করছি স্যার, ঢুকছে ফোনটা ঢুকছে না, দাঁড়ান করছি নি, দাঁড়ান দেখছি। হ্যাঁ স্যার বলুন স্যার, কর্মকার স্যার। হ্যাঁ কর্মকার স্যার বলে দিয়েছে আমি স্যারকে।
কি বলছে?
বলছে জয়েন করছি, বুঝতে পারছে না, বেরিয়ে গেছে, বুঝতে পারেনি।
ওকে
নেটওয়ার্কের জন্য।
ওকে
হ্যাঁ
Dr. Saha.
Yeah, it's okay.
That network issue, sir. He is joining.
Understood. Sir, please unshare your screen so that I can share my screen.
Unshare my screen, na?
Yes, sir.
Your screen sharing, this one, I should unscreen it, isn't it? Okay. Is it okay?
No, sir, please unshare your screen, sir. On the upper menu, there is there is a tab that is stop sharing.
Stop sharing.
So upper panel, sir, in the just middle side, you can see one stop sharing. Just you have to just.
Sir, can you please accept the request? I send you a request, sir, for remove control your screen. Can you please accept it?
Oh, stop sharing.
Yeah. It's fine. So just 1 minute. Give me 1 minute.
Yes, is it okay?
Yes, sir. Yes, sir. Now Suman will share screen, sir. No problem.
Yes. Good evening, everybody. We'll be discussing today GDM Updated. Now, what is GDM? It is one of the most common medical complications of pregnancy. It affects mothers, fetus, and outcome of pregnancy. Hence, early detection is necessary. It is defined as impaired glucose intolerance with onset or first recognition of pregnancy. Undiagnosed or inadequately treated GDM can lead to significant maternal and fetal outcomes. Next, please. Now, let us see the prevalence. What is the prevalence of GDM in India? As per one study that was conducted in Tamil Nadu, prevalence of GDM is found to be approximately 7.6%. Around 6.2 million live births are affected by hyperglycemia in pregnancy, of which 5.9 million are due to GDM. And difference in GDM in urban is to rural distribution is in Tamil Nadu study, they found it to be in urban areas, its prevalence was 17.8%. Whereas in semi-urban areas, it was approximately 13.8, which are more or less nearly similar, but in rural areas, it was much lower, that is around 9.9%. As next one. Now, what about the guidelines? How to diagnose GDM and how to define GDM? GDM is defined as carbohydrate intolerance resulting in hyperglycemia of variable severity with onset or first recognized during pregnancy. It is also defined in this way, includes women with undiagnosed pre-existing diabetes as well as women with first onset hyperglycemia during pregnancy. Maybe the lady had already pre-existing diabetes or she had first onset of hyperglycemia only during this pregnancy. In the past, less severe GDM was referred as impaired glucose intolerance and more severe as GDM. But now, the whole higher end of glucose spectrum is more simply referred as GDM. FIGO recommends that the term hyperglycemia in pregnancy, whether the diabetes is before pregnancy, during pregnancy, or because of pregnancy, they are all referred as GDM. Next one. Now let us see the problems. What are the short-term and long-term complications of mother and offspring due to GDM? For mother, in pregnancy, we get first abortions. then preeclampsia and its subsequent and its associated complications. During labor, we get more incidences of induction of labor, more incidences of cesarean section. Operative interventions are much more higher. That may be either instrumental deliveries or cesarean deliveries, and labor complications are also much more. In postpartum period and beyond, this woman may suffer from subsequently type 2 diabetes and recurrent GDM. To the fetus or offspring, they may have congenital problems like central nervous system problems, cardiac problems. Then there might be problems of fetal programming like large for that fetus, macrosomias, or the babies may have increased fat mass. Neonatal complications are prematurity, parental asphyxia, respiratory distress, metabolic complications. There is hypoglycemia and hypocalcemia, polycythemia and hyperviscosity, low iron stores, hyperbilirubinemia, and cardiomegalopathy or cardiomyopathy. And long-term outcomes are increased incidence of obesity, higher incidence of type 1 diabetes and type 2 diabetes, and metabolic syndrome. These are some of the complications which covers both short-term as well as long-term complications to both mother as well as to the babies of GDM patients. Next one. Now, what are the consequences if GDM is not diagnosed and remains untreated? To the mother, they may have preeclampsia, as we told earlier. They are more prone to develop infections, birth lacerations, cesarean deliveries, and long-term sequelae. Fetal complications are growth abnormalities, polyhydramnios, fetal demises, neonatal birth injuries, hypoglycemias, seizures, polycythemias, electrolyte imbalance, hypocalcemia, hypomagnesemia, hyperbilirubinemia, and respiratory diseases. Next one. Now, how to identify a patient with GDM? How to screen and how to test. For GDM, oral glucose tolerance test, that is OGTT, is generally the diagnostic test of choice. This test is usually administered at the first antenatal visit and subsequently in between 24 to 8 weeks of gestation. A plasma blood sugar, a plasma sample is taken following overnight fasting, and then 75 gram or 100 gram glucose is given, and further plasma blood samples are obtained at 1, 2, and 3 hours. That is, whole thing is what? The plasma blood sample is obtained following overnight fasting, and this fasting should not be less than 8 hours. And then 75 gram or 100 gram glucose load is given, and further blood samples are obtained at 1, 2, and 3 hours. GDM is diagnosed depending on criteria used. If 1, 2, or more glucose levels are equal or exceeds the reference values. This was adopted from Endocrinology Committee of FOGSI in March 2021. Next one. Screening and testing continued. The American College of Obstetricians and Gynecologists, ACOG, and UK National Institute of Health and Care Excellence recommended that women who have had the GDM in the previous pregnancy should be offered diagnostic testing. ACOG also recommends early testing in obese women and women with impaired glucose metabolism as early as possible to identify undiagnosed type 2 diabetes. Australian Diabetes in Pregnancy Society recommends risk for assessment in early pregnancy. Risk factors are ranked by severity and either one high risk factor or two moderate risk factors They are needed before OGTT is offered. Next. The proposed guideline for screening of GDM in India. The government of India and NHM, National Health Mission, has proposed the following screening procedures. This is universal screening for Indian women. Universal screening at first booking, that is your first trimester. Fasting plasma glucose to be tested. And if fasting plasma glucose is less than 92, the patient is believed to be non-GDM. And she needs single-step OGTT to be done using 75 gram in the fasting state at 20 to 48 weeks of pregnancy. Subsequently, those patients who got fasting sugar range in between 92 to 125 milligram per DL, they are diagnosed to be GDM. If their blood sugar is in between 92 to 125, they are gestational diabetes mellitus. Once the fasting blood sugar is more than 120, or if their glycosylated hemoglobin is more than 6.1, this category of patient, they are over diabetes. Now coming back to again those patients who had less than 92 milligram per DL, who were once thought to be non-GDM, they had again single step OGTT done at 24 to 28 weeks of pregnancy with 75 gram of glucose. And using ADPSG criteria for GDM, that is your fasting glucose 92, 1 hour glucose 180 and 2 hour 153. Any abnormal value were taken to be GDM. And if values are normal, then they are thought to be non-GDM. In high risk cases, repeat GTT can be done at 32 weeks of pregnancy. Next one. Yes, these are basically different criteria used to diagnose GDM. And most of the readings are given in moles. And moles, these are just to be converted to milligram per DL. Once it is multiplied by 18, we get the result in milligram per DL. Okay, next one. Now, what are the protocols as given by Foxy for investigation? Testing for GDM is recommended twice during antenatal care. The first testing should be done during first antenatal contact as early as possible in pregnancy. The second testing should be done during 24 to 28 weeks of pregnancy if the first test is negative. It is important to ensure second test, as many pregnant women develop blood sugar intolerance during this period only. The test is conducted for all pregnant women, even if she comes late in pregnancy for antenatal checkup for the first time in their first contact. And if she presents beyond 28 weeks of pregnancy, only one test is sufficient. Next slide, please. Now, universal screening program that is as suggested by Government of India Health and Family Welfare Department. Pregnant women testing for GDM at first antenatal visit with 75 gram oral glucose and 2 hour blood sugar is to be taken. Any pregnant woman who comes for antenatal checkup, at first antenatal contact, 75 gram oral glucose load, and after 2 hours, blood sugar is to be taken. Now they are positive if 2-hour blood sugar is more than 140 per dl and should be managed as GDM as per guideline if they are more than 140. Negative if the 2 hours blood sugar is less than 140 and repeat testing is to be done at 24 to 28 weeks of pregnancy. If they are negative, they are taken. Once it is less than 140, they are taken to be negative and they are managed as normal throughout her pregnancy. But if they are more than 140 milligram per dl, they should be managed as GDM as per government guideline. Okay, next one. Yes, before going to this slide, can I see the previous slide once more? Yes, this slide. Now, testing, as we say, the testing for GDM at first antenatal visit should be done with 75 gram oral glucose. Now, this is immaterial whether the patient comes in empty stomach or with full stomach. Irrespective of our meal, it can be done, number one. Number two, 75 gram glucose is to be mixed with at least 300 ml of water. And the mixture is to be taken within 5 to 10 minutes. Then only after 2 hours, blood sugar should be evaluated or assessed. And one more interesting thing is, yes, some patient may vomit out because they are taking blood sugar within 5 to 10 minutes of time. If there is vomiting within 30 minutes, that is less than 30 minutes, the test is withheld on that day. And patient is advised to do the test on next visit or next day or after 24 hours. It is like that. So the important things are, this test, it is immaterial whether the patient comes in empty stomach or full stomach or after meal or before meal. The amount of fluid or amount of water should be approximately 300 ml. It should be consumed within 5 to 10 minutes. If there is vomiting within 30 minutes, the test should be invalid or should not be continued. And if vomiting occurs beyond 30 minutes, then it should be continued or it can be done. Next one, please. Now, management of GDM, the guidelines or the guiding principles are, all pregnant women who test positive for GDM for the first time should be started on medical nutrition therapy, that is MNT, and physical exercises for 2 weeks. The MN should walk or exercise for 30 minutes a day. And after 2 weeks of MNT and physical exercise, 2 hours PPBS, that is your post-meal, should be done. Thus, GDM is managed initially with MNT and physical exercise. And if it is not controlled with MNT, either Metformin or insulin therapy is added to MNT. So if 2-hour people blood sugar is less than 120 milligram per dl, repeat test every month during second and third trimester is needed. And more follow-up tests can be done as recommended by treating physician. And if PPBS is more than 120, medical management, either Metformin or insulin therapy is to be started as per guideline. So basically, For 2 weeks, they should be advised physical exercise and medical nutrition therapy. Next one, please. Next slide, please. Balanced meal plan, which promotes optimal nutrition for fetus and the baby and the mother. Previous slide, please. Yes, please. Educate energy for appropriate gestational weight gain, achievement, and maintenance for normoglycemia should be as follows. Diet should be balanced as follows. Carbohydrate 50 to 60% of total diet, protein should be 20 to 25%, and fat should be 25%. Hypocaloric diet in obese women with GDM can adversely impair fetal growth and besides ketonemia and ketonuria. As per ICMR guideline, for an average weight gain of 10 to 12 kg, an addition of 350 kilocalorie per day above the adult requirement is recommended during second and third trimester of pregnancy. Severe calorie restriction is not recommended as it may result in ketonemia and ketonuria and impair physical and mental development of offspring. So while starting medical nutrition therapy, we should have some prior knowledge about the composition and content of diets of our people. Next slide, please. Principles of MNT, healthy eating during pregnancy. Metformin or insulin therapy is the accepted when blood sugar levels of pregnant women with GDM is not controlled with MNT. Insulin can be started anytime during pregnancy for GDM management if the woman's blood sugar is not controlled with maximum dose of metformin, that is up to 2 grams a day. And this metformin should be started at 500 milligram twice daily, and gradually it can be go up to, or we can go up to 2 grams a day. Hypoglycemia and metformin are less in comparison to insulin. The common side effect that occurs with metformin include only GI problems mostly, that is your diarrhea, nausea, stomach pain, heartburn, gas, and serious side effects are lactic acidosis, and very rarely we get low blood sugar. Next one. Regarding insulin, insulin is the drug of choice in pregnancy. Either extrapid or mixed insulin can be given in pregnancy. In a simplified form, dose requirement can be decided as follows. In first trimester, 0.7 units of insulin per kg body weight. In second trimester, 0.8, and third trimester, 0.9. And at term, 1 unit per kg body weight. But these figures, they are very difficult to be calculated at times. And when we get difficulty, we can start with 4 units of either ectopit or mixed insulin 3 times a day before breakfast, along with lunch or dinner, and then titrate twice a week and adjust the dose. We can start with 4 units 3 times a day and then titrate twice in a week. Mixed insulin are 30% rapid-acting insulin and 70% isopen insulin, and 2/3 of these dose is to be given in morning with breakfast, and 1/3 is given at night. And when the fasting sugar is more, then the night dose of insulin is to be enhanced or increased, and if PP blood sugar is more, increased. Next slide, please. Now with metformin, the chances of hypoglycemia is much less, but with insulin, yes, there can be. And any pregnant woman on insulin can develop hypoglycemia at any point of time. They are diagnosed to be hypoglycemic once their blood sugar level is less than 70 milligram per dl. And how to recognize? The early symptoms of hypoglycemia are tremors of hands, sweating, palpitation, hunger, easy fatigability, headache, mood changes, irritability, low attentiveness, tingling sensation around the mouth, lips, or any other abnormal feeling. In severe cases, there might be confusion, abnormal behavior, or both, visual disturbances, nervousness, or anxiety. And uncommon findings may be seizures or even loss of consciousness may at times be present. But most of the time we find the early symptoms of tremor and sweating and hunger. Next slide. How to manage hypoglycemia? Ask a woman to take 3 TSF of glucose powder, that is 15 to 20 grams, dissolved in a glass of water. If glucose is not available, take one of the following materials: sugar, 6 teaspoonful in a glass of water, to juice, honey, anything which is sweet or any food may be helpful. After taking oral glucose, she must take rest and avoid any physical activity 15 minutes after taking glucose. She must eat 1 chapati with vegetable rice or 1 glass of milk, idli, fruit, anything eatable which is available. If hypoglycemia continues, repeat same amount of glucose and wait. If pregnant woman develops more than one episode of hypoglycemia in a day, she should consult a doctor immediately. Next slide. Now, what are the special obstetric care for pregnant women with GDM? Antenatal care. In case of diagnosed GDM before 20 weeks of pregnancy, a fetal anatomical survey by EVG should be done in between. Though it is written to be 18 to 20 weeks, it should be done in between 18 to 22 weeks, because most of the cardiac anomalies which are detected or best detected in between 20 to 28 weeks of pregnancy. So it can be done up to 18 to 22 weeks of pregnancy. And for all pregnancies with GDM, a fetal growth scan should be repeated at 28 to 30 weeks of gestation. And again, we should repeat the scan in between 34 to 36 weeks. There should at least be 3 weeks of gap between 2 ultrasound, and it should include fetal biometry and amniotic fluid estimation. Next one. Fetal surveillance in pregnant women with GDM. GDM patients are at increased risk of fetal death in utero, and this risk is increased in pregnant women requiring medical management. Once the medical management is needed, then the chance becomes much more for the fetus to die in utero. So how long does it take to count up to 10? If the fetus does not kick 3 times within 1 hour or a minimum of 1 time in 1 hour, she should consult a doctor. Next slide, please. Labor and delivery. Timing of delivery. GDM pregnancies are associated with delay in lung maturity. It is known fact. So routine delivery prior to 39 weeks is not recommended. If pregnant woman with GDM, which is well controlled, that is your blood control, if it is nicely controlled, and has not already delivered spontaneously by 39 weeks, induction of labor should be done or scheduled at or after only 39 weeks of pregnancy. In pregnant women with GDM with poor blood sugar control, those with risk factors like hypertensive disorders of pregnancy, previous stillbirth, or other complications should be delivered earlier. Vaginal delivery should be prepared, and LSCS should be done for obstetric indications only. In case of fetal macrosomia, estimated weight of the fetus, if it is more than 4 kg, consideration should be given for elective cesarean section at 39 weeks to avoid shoulder dystocia and birth injuries during delivery. Next slide, please. But one thing to be remembered is that cesarean section is needed only for obstetric regions in well-controlled patients. Special precautions to be taken during labor. With GDM, on medical management, metformin or insulin, blood sugar monitoring is required during labor by glucometer. The monitoring dose of insulin or metformin is withdrawn on the morning of the day of labor or induction. And the pregnant woman should be started on 2-hourly monitoring of blood sugar.
Sorry for the interruption, sir.
Saline.
Galaxy A71, kindly mute.
Pardon?
No, it's okay,
Hello?
sir. Yeah, it's okay, sir.
IV infusion with normal saline to be started, and regular insulin can be added according to blood sugar level as per the table given below. If the blood sugar is in between 90 to 120, no need of use any insulin. In between 120 to 140 milligram per dl, we should add 4 units with 500 ml. In between 140 to 180 milligram per dl, 6 units. And if the blood sugar is more than 180 per dl, 8 units of insulin is to be given. But here the rate of flow was written to be 100 ml per hour. and which was written to be 16 drops per minute, but actually 16 drops is equivalent to 1 ml. So it will be around 60 ml. So it should be approximately 25 drops a minute. Next slide, please. All the units should receive immediate essential newborn care with emphasis on early breastfeeding. So post-delivery follow-up of pregnant women with GDM. Immediate postpartum care of women with GDM is not different from other women, but these women are at high risk of development of type 2 diabetes mellitus in future. Maternal blood level usually comes down to normal after delivery. We have seen many patients whose blood sugar come down immediately after delivery of the placenta. If you see the blood sugar after delivery of placenta, it will be approximately 70, 80, like that. Though that patient was getting say around 20 to 30 units of insulin beforehand, just delivery of the placenta is sufficient. Subsequently, 75 gram OGTT, there is your fasting and 2-hour PP at 6 weeks postpartum to evaluate her glycemic status is done. Pregnant women with GDM and their offspring are at increased risk of development of type 2 diabetes mellitus if later life. They should be counseled for healthy lifestyle and behavior, and particularly role of diet and exercise. Next one, next slide, please. And before next slide, I'm going to speak a few words that this patient, though they have normal delivery, as per Government of India guideline, usually following delivery, we discharge patient after 48 hours. But here in diabetes, we cannot discharge them after 48 hours because we need to evaluate her blood sugar as per Government of India guidelines on 3rd day, and only after that, if everything is normal, we should discharge her. So we'll do her blood sugar on 3rd day, number 1. Number 2, in between 6 to 12 weeks of pregnancy, postpartum period. Number 3, at 6 months interval. And subsequently, every year we should ask her to do blood sugar. Who should be screened early? What are the guidelines? The American guidelines are ACOG had adopted the NIDDK or ADA guidelines on screening for diabetes and pre-diabetics, which considers not only previous pregnancy history but also risk factors associated with type 2 diabetes mellitus. To consider early screening if when we will do early screening, if the patient is overweight with BMI of 25, 23 in case of Asian Americans, and one of the following criteria, that is your physical inactivity, non-impaired glucose metabolism, previous history of what GDM, macrosomia, that is your fetus weighing more than 500 grams, or they got history of stillbirth. And this factor is, this is your very commonly we get this factor, stillbirth. Hypertension 140/90 or more, or being treated for hypertension, HDL cholesterol less than 35, fasting triglycerides more than 250, percent with PCOS, acanthosis nigricans, non-alcoholic steatohepatitis, morbid obesity, and other conditions associated with insulin resistance. In patients whose glycosylated hemoglobin is more than 5.7, impaired glucose tolerance or impaired fasting blood sugar, if glycosylated hemoglobin is more than 6.5, diagnosis of pre-gestational diabetes is made and GTT or GTT not needed. GCT or GTT is not needed. Cardiovascular diseases, family history of diabetes mellitus in first degree relatives, that is your parents or siblings, they all should have screening at the earliest. Yes, next one, please. Now, what about guidelines of SEOG in respect to diet and exercise, nutritional assessment and plan, counseling by registered dietitian, nutritionist, and their team if available. Recommend complex carbohydrates instead of simple carbohydrates. 3 meals in a day, that is your 3 major meals and 2 snacks to limit glucose fluctuations. Ideal calorie distribution between carbohydrate, fat, and protein not yet known. Which one is carbohydrate? Though we have said or minimum 150 minutes a week should be sufficient. It improves
Pardon, sir, your voice is breaking some. Sir, you were in mute.
yes. Next slide, please. Now, what are the pharmacological treatment as per SEOG guidelines? SEOG recommends that insulin be the preferred therapy if glycemic control is not obtained with non-pharmacological treatment. Substantial number of patients started on oral therapy will require insulin during pregnancy. Starting insulin dose is 0.7 to 1 unit per kg body weight per day. Those should be divided, and long-acting or intermediate-acting insulin in combination with short-acting and insulin should be used. Individualized based on patient's glycemic pattern. Short-acting analogs, that is insulin lispro and aspart, they are preferred over regular insulin due to more rapid onset of action. NSP insulin and pH insulin, I mean to say, is still used, but insulin glargine and detemir available for long-acting coverage only. Yes, please, next slide. If the patient cannot take insulin or declines, metformin can be used. Though earlier it was believed that metformin should be given only after 20 weeks of pregnancy, there are evidences are now coming up that even if metformin is given from early weeks of pregnancy, it creates or causes no problem. So let her be counseled about metformin risk, including placental crossover. Insulin, metformin crosses over the placenta, and no long-term studies in offspring is available. that is your long-term study of metformin on fetus is not available yet as on today. It is maybe associated with, there is a query maybe, with preterm birth. Starting dose should be 500 milligram nightly for 1 week, increase 500 to 500 twice daily, and then go up to 2 grams. Check the baseline creatine. If the renal function or creatine is high, it is not to be given. It is not cannot be increased. Adverse events include abdominal pain, diarrhea, as we have said earlier. Maximum dose of 2.5 to 3 grams per day. But these are all American guidelines. But for us, probably in Indian situation, it is approximately around 2 grams a day. Glyburide should not be used in place of insulin, and studies show worse outcome, including macrosomia and birth injury. Starting dose of 2.5 to 2 milligram per day in divided doses. Up to 30 milligram may be necessary to obtain glycemic control. Long-term outcome studies also still lacking, although no short-term adverse events is noted. Next slide, please. Now, what about fetal monitoring? On medication, that is your A2 GDM, with poor control and without comorbidities at 32 weeks, begin earlier if other comorbidities are present. Fetal assessment of A2 GDM in general is usually recommended based on the understanding that there may have been poor control at some point of time during pregnancy. Well control on diet, there is A2 GDM. No consensus due to lack of data demonstrating stillbirth risk. Fetal assessment may not be necessary in A1 diabetes mellitus, and if performed, usually begun later than A2 diabetes. It can be based on local practices, include amniotic fluid volume assessment due to risk of polyhydramnios, which is more commonly found. Next one, please. When to deliver? HUG guideline is, it is more or less the same. In control on diabetes, in control on diet, they should go up to or beyond 39 weeks of pregnancy. Expectant management up to 40 weeks, 6 days is appropriate with antepartum testing. Well controlled on medication, deliver at 39 weeks, 0 days to 39 weeks, 6 days of pregnancy. Poorly controlled, expert guidance, support earlier delivery, but data lacking regarding the pieces time. Delivery in between 37 weeks to 38 weeks, 6 days may be justified. Delivery between 34 to 36 weeks, 6 days is reserved for failure of in-hospital glycemic control if sugar control is not good and if there is abnormal fetal testing. Estimated fetal weight gain of more than 4.5 kg, counsel regarding risk and benefits of scheduled cesarean section. Yes, next slide, please. Nice guidelines. The new updates, that is up to 2020, but I think subsequently there are some guidelines. The NIST guideline now recommend offering continuous glucose monitoring to all pregnant women with type 1 diabetes to help them meet their pregnancy glucose target and improve neonatal outcome. Their evidence review based on the concept randomized trial and Swedish observational study found that compared to capillary blood glucose monitoring, CGM resulted, that is a continuous glucose monitoring, resulted in more women achieving their blood glucose target, fewer cesarean sections, and fewer neonatal intensive care admissions. They concluded that there was high quality evidence that CGM was associated with better clinical outcome and a 90%, 94% chance of CGM being cheaper than capillary glucose testing. NICE did not provide a clear guideline for time in range pregnancy glucose target, which are more than 70% CGM time in range, less than 25% time above range, and less than 40% time below range in type 1 diabetes in pregnancy. Next slide, please. Next slide, please. So the key recommendations of NICE guideline are: the NICE research recommendations identified a need for qualitative research focused on exploring the barriers to achieving pregnancy glucose targets, to examine the effectiveness and acceptability of insulin pump therapy and continuous glucose monitoring used in women with diabetes who are planning pregnancy, to establish if earlier testing, diagnosis, interventions for gestational diabetes improves maternal, fetal, and neonatal outcome, including fetal hyperinsulinemias, to explore the barriers to achieve pregnancy glucose target in women with gestational and pre-gestational diabetes, to determine the most clinically and cost-effective approaches for identifying fetuses most at risk of death, to investigate what pharmacological interventions may delay or prevent type 2 diabetes developing in women with gestational diabetes mellitus. So these are the recommendations of NICE for exploring possibility of continuous glucose monitoring. Next slide, please. Yes, this is again NICE guideline updated for pregnant women with type 2 diabetes. The maternal glucose level are the key modifications, modifiable predictors of perinatal death. That is true. Maternal glucose level are the key modifiable predictors of perinatal death. If we can modify the blood sugar, then fetal death definitely will be reduced. NICE did not comment on the role of glucose monitoring for the growing number of pregnant women with type 2 diabetes. Women with type 2 diabetes are mentioned indirectly as pregnant women who are on insulin therapy but do not have type 1 diabetes. They have critically mentioned it. They can be considered for CGM if they have problematic severe hypoglycemia with or without impaired awareness of hypoglycemia, which applies to minority, that is hardly 2 to 3% of women with type 2 diabetes. However, use of CGM or flash can be considered for pregnant women with unstable blood glucose levels that are causing concern despite efforts of optimized glycemic control. Pregnant women with type 2 diabetes and glycosylated hemoglobin less than, more than 48 millimole per mole, that is your 6.5%, have by definition unstable glucose level. Pregnant women with type 2 diabetes where glycosylated hemoglobin is more than 6.5, by definition they have unstable glucose level and are at increased risk of stillbirth and neonatal deaths. So flash should be considered for all women in this category. Either flash or continuous glucose monitoring system should be used. Flash may be suitable for pregnant women with type 2 diabetes. More data regarding clinical effectiveness of flash and CGM and appropriate pregnancy glucose target of glycosylated hemoglobin and CGM in time range marriage and urgently needed in type 2 diabetes pregnancy. Next one, please. This is again gestational diabetes criteria as per American Diabetic Association standard medical care in diabetes. That is your screening test and diagnostic criteria. So all the pregnant women at the first prenatal visit screen for undiagnosed type 2 in those with risk of or risk factors as listed in table 1. The tests are done to be our standard diagnosis test and criteria as listed in table 2 again. 75 or 100 gram glucose and more than 140. These are all the things. So next slide, please. Yes, some latest information from ISRE abstract book in June, July 2021. That is it was published in Human Journal. Women with hypothyroidism were more likely to suffer from gestational diabetes mellitus, hypertensive disorders of pregnancy, gestational hypertension, and preeclampsia. And one more ISRE finding is, next slide please. In next slide we are getting it. So smokers, be careful. So after controlling for confounding effects, women who smoke during pregnancy are at increased risk of development of gestational diabetes. This was also published in ISRE abstract book in June, July 2021. Next slide, please. Metformin in PCOS for preventing GDM. Metformin is not recommended for prevention of GDM in women with polycystic ovary syndrome and infertility who become pregnant while taking metformin. So they said that metformin is not recommended for prevention of GDM. Overall, in women with PCOS and infertility who become pregnant while taking metformin, they should continue it. Yes, next slide, please. Next slide, please. So general considerations for diet therapy. The goal of diet, there is something wrong. Next slide, please. The goal of therapy may be achieved by general consideration of diet therapy by controlling calorie intake, tailored to maternal and neonatal need, so that the mother can gain proper weight during pregnancy by dividing her meal intake. And avoiding long fasting, they should be asked not to fast. It is recommended to receive 20% calorie intake from protein, 50% from carbohydrates, and 30% from fat with a proper distribution. Next slide, please. So, can glucocorticoids be prescribed to improve fetal lung maturity in GDM? Yes. Glucocorticoids can be used in GDM to improve lung maturation if premature delivery is suspected or determined. But this is a weak recommendation. What are the considerations for the use of glucocorticoids? If pregnant women under insulin therapy who require glucocorticoid for fetal lung maturation, the insulin dose should be increased accordingly. In these cases, hospitalization and blood sugar monitoring are highly recommended. In women with GDM, an acceptable glycemic control without insulin therapy, warning about the risk of hyperglycemia and close monitoring of blood sugar is advisable if low corticoids would be prescribed. And it is observed that after 6 to 8 hours of injecting glucocorticoids, the level of blood sugar rises most. And that is the time when we need to increase the dose of insulin. Next one, please. Next slide, please. These are all for COVID eras. So there are some adaptations. In the evolving pandemic, highly infectious virus, screening for OGTT involve high exposure risk to healthcare providers. So people are now in this period, they are avoiding OGTT at 24 to 28 weeks of pregnancy, and they are offering glycosylated hemoglobin along with fasting plasma glucose or even random plasma glucose. Yes, next slide, please. This slide gives us the elaborate things regarding level of glycosylated hemoglobin, RPGs and FPGs. Screening for gestational diabetes in evolving endemic area. That is in between 8 to 2 weeks of pregnancy coincide with booking visit. If glycosylated hemoglobin is more than 6 or RPG is more than 200, she is about diabetes in pregnancy. Or they are early diabetic if your blood sugar is in between 62 to 200 or glycosylated hemoglobin is in between 5.9 to 6.5. Okay, and in between 28 weeks of pregnancy, 24 to 22 of pregnancy, here also they are considered to be diabetic if the levels are glycosylated hemoglobin is less than more than 5.7, RPG, FPG is more than 100, and RPG is more than 162 milligram. They are all diabetic, and they are considered to be non-diabetic if glycosylated hemoglobin less than 5.7, RPG is less than 162, and if FPG is less than 100. So basically to say that to consider to be non-diabetic, it should be glycosylated hemoglobin should be less than 5.7. Fasting plasma glucose should be less than 100, and random blood sugar, it should be less than 160. Next slide, please. So this is again management of GDM in COVID era. This is very elaborate. More or less, it is the same thing they have said, but it is very difficult. It will be very difficult to see. So basically, on GDM diagnosis, hospital, that remote consultation in community level. From GDM onset until 36 weeks gestation, remote consultation, community consultation. Then at 36 weeks, you should hospitalize her. Next slide, please. Now, what about the role of myo-inositol? These are new evidences which are coming up nowadays. The Curious has given a conclusion as on these data regarding myo-inositol. A cumbersome administration method of high chance of side effects such as hypoglycemia and weight gain have made insulin a problematic and debatable option for prevention of GDM. However, the nutrition supplement, that is your myo-inositol, has been shown to be a safe and easy to administer alternative. Myo-inositol is believed to be working better. Based on current evidence, myo-inositol supplementation reduces the risk of GDM among obese and overweight pregnant women as well as women with PCOS or a family history of type 2 diabetes mellitus. So these are the categories of patients where it was tested and it was found that myo-inositol supplementation reduces the risk of GDM. Next one, please. Next slide, please. One more evidence was there. Efficacy of myo-inositol in treatment of gestational diabetes mellitus in Asian Indian women, a pilot randomized clinical trial. Here it was observed that 2 gram myo-inositol orally given when started soon after diagnosis of GDM as adjunct to dietary modifications, it is effective in achieving glycemic control. 2 gram orally. Oral myo-inositol supplementation is effective in treating GDM, thus decreasing the need of pharmacological therapy. So baseline glycosyl or hemoglobin is an independent risk factor to predict the need of insulin. Next slide, please. So myo-inositol is coming with a new promise that can be given probably or will be added subsequently. It is believed that myo-inositol, due to its insulin mimetic qualities, activates GLUT4 translation of the plasma membrane and then leads to increase the glucose transport through GLUT4 into the cells. According to these theories, myo-inositol could reduce the insulin resistance in pregnancy, and myo-inositol supplementation could increase the action of endogenous insulin. Next one, please. Next slide, please. This is again another scientific report. Here it was, no, previous slide, please. Yes. So combination of myo-inositol and alpha-lactalbumin, that is combination of, now it has again come to myo-inositol as well as lactalbumin may reduce the insulin resistance and excessive fetal growth in women with GDM. Furthermore, a reduced rate of insulin treatment and preterm birth was demonstrated in the treated group. That is your who were treated with myo-inositol and lactalbumin. The preterm birth was much more less. Okay, coming to the take-home message. Next slide, please. The take-home message for today's discussion is Gestational diabetes mellitus can be easily controlled by diet and exercise. Only in few women whom controlled by diet and physical exercise, oral antidiabetic and insulin are required. GDM can be treated with oral metformin as they do not harm the fetus. Insulin injections are required only during pregnancy, and insulin will be stopped in most of the cases immediately after pregnancy. Insulin is in abdomen. If injected, it is 100% safe. Modification of diet is very safe. Switch should be avoided all the time during pregnancy. If blood sugar is controlled, patient and her baby both are safe and healthy. Pregnant women with GDM should deliver healthy at health facilities. There is no scope for domiciliary delivery or home delivery. They should be delivered in hospitals. It will help in management of any complications which can be encountered during the process. So thank you. This is all about what we were supposed to talk on GDM, what is new.
Thank you very much, sir, for this nice and informative presentation. Just give me 1 minute time to check whether any question is there in our dashboard, sir. Sir, thank you very much. Just one question, sir. That is there any necessary to check this postpartum GDM, or is it subsequently go away?
No, it is BAP. So as I told you right now, following delivery, even if it is normal delivery on D3, on third day, you should do blood sugar test. That is one. Number two, at 6 to 12 weeks postpartum, you should have a thorough evaluation. Then at 6 months, then every 1 year, you should have evaluation.
Okay, thank you, sir. Thank you very much, sir. And another question is, sir, what is your thought on this thyroid? Means hypothyroidism. Does it have any effect on this GDM, or
yes, with the incidence of GDM is or sugar intolerance is much more higher in patients who have thyroid problems, both hypo as well as hyper.
So thank you very much, sir. I could not find any other question right now. So thank you very much once again for your valuable time to talk on this very emerging topic on this GDM and what is the current recent update on that GDM. And thank you very much once again. And in future also, we look forward for some valuable session with you, sir.
Thank you.
Thank you, sir.
Thank you very much, sir. Thank you. Have a good day, sir.